Morphine, the prototypic opioid agonist, has been known for centuries to relieve pain with remarkable efficacy. First isolated from the opium poppy in 1803, it was named after Morpheus, the Greek god of dreams. And at Sketchy, you can think of it as a dream vacation to none other than our very own world-class Utopia resort. That's Utopia for opiates. The term opioid refers to all compounds that work at opioid receptors. 3 major classes of opioid receptors have been identified: mu, kappa, and delta receptors, and they're found throughout the nervous system and GI tract. See the sign for the massage parlor? The mu opioid receptor is the major analgesic opioid receptor, like a comforting massage, or in this case, a pain-relieving acupuncture session. Most of the agents we'll cover in this sketch have some kind of activity at mu opioid receptors. In fact, almost all of the clinical and adverse effects you'll encounter on the exam are mediated by mu opioid receptors, including analgesia, sedation, constipation, and respiratory depression. At the molecular level, opioid receptors, once activated, interact with G proteins to affect ion channel gating. In neurons, specifically, opioid agents cause potassium channels to open, leading to hyperpolarization of the cell and inhibition of signal transmission. Just think of these open barrels of those recurring potassium bananas. One of our convenient snack carts is never too far away when you're in Utopia. What's that? Craving something a little more refreshing? How about a frosty cup of calcium ice cream? Turns out that opioid receptor activation also causes the closure of voltage-gated calcium channels. Notice that the calcium coolers are closed at all times to maintain that ultimate frosty freshness. This closure of voltage-gated calcium channels occurs on presynaptic nerve terminals, thereby reducing transmitter release. To show presynaptic inhibition, specifically, one of the resort workers winds up the presynaptic wire to the voltage-gated calcium cooler. This presynaptic action depresses the release of numerous neurotransmitters, including glutamate, the excitatory transmitter released from nociceptive nerve terminals, as well as acetylcholine, norepinephrine, serotonin, and substance P. All in all, what you're doing is stopping the transmission of pain signals to the brain. And as the sketch progresses, we're going to illustrate the agents that act as either full agonists, partial agonists, or antagonists at opioid receptors. The majority of opioid analgesics act primarily at the mu opioid receptor. So let's head back over to the massage area. See that sign challenging you to make your pain a fantasy? Let it remind you of fentanyl, an opioid analgesic used for postoperative and chronic pain. And that slogan, promising more fun, less pain, should remind you of morphine, as well as its derivatives such as hydromorphone, used in the management of severe or chronic pain. The analgesic tramadol also shows some low affinity binding to the mu opioid receptor. Tramadol will be represented here by the resort's exclusive tramadol tram, and because it's only a weak mu agonist, we've kept it off in the background of the sketch. Tramadol's centrally acting analgesic properties are based instead on blockade of serotonin and norepinephrine reuptake. And if you take a close look at the side of the tram, you'll notice that we've included the north-south compass, our recurring symbol for norepinephrine and serotonin reuptake inhibitors. All right, here's the thing you need to keep in mind with these potent opioid analgesics. Those mu receptors you're activating in order to bring about analgesia and euphoria are the same receptors responsible for the numerous adverse effects associated with opioid use, including meiosis, respiratory depression, and physical dependence. On the exam, one of the most important side effects to know is constipation. Mu opioid receptors exist in high density in the GI tract, where they modulate the activity of the enteric nervous system. And at the massage parlor, you'll notice one of the massage tables looks suspiciously like a colon with some supple haustra for extra comfort. I mean, just look at that cecum. So plush. In the stomach, small intestine, and large intestine, motility is decreased while tone is increased. This delays the passage of stool, allowing increased absorption of water and constipation. This effect can also be used clinically, however, as our next guest down here takes off those soiled slippers from the mud bath. Let this image remind you of agents used to combat diarrhea. Loperamide, for example, is a mu-opioid agonist. At Sketchy, loperamide is represented by these cute loperamide lop-eared rabbits, part of some advanced massage technique, I guess. They know what they're doing. Opioid agonists increase colonic phasic segmenting activity. In other words, the tract squeezes down on stool instead of pushing it along. Just think of these two loperamide rabbits here lopping back and forth on your colon. The circular rings of muscle kind of squeeze down in succession, pushing stool back and forth in your Haustra pouches. Back and forth. Diphenoxylate is a prescription opioid agonist also used as an antidiarrheal agent, represented here by these diphenoxylate dolphins. Again, think of two dolphins hopping back and forth between your Haustra, increasing that phasic segmenting activity. Back and forth. Back and forth. Keeping your stool from moving along. Another well-recognized action of opioids is cough suppression. Just take a look at this coughing guy here as he breathes in those vapors from our state-of-the-art sauna facilities. Codeine, in particular, is commonly used to manage pathologic cough, and it's represented by this bar code here stamped onto that ridiculously huge bag of cough drops. Another opioid derivative commonly used as an antitussive is dextromethorphan. Look closely at that bag of cough drops and you'll see it's by the brand of Little Orphan cough drops, with that coughing dextromethorphan orphan. Why the desert setting on the packaging? Well, the noble and nomadic camel is our recurring theme for NMDA, of course. Besides mu-agonist activity, dextromethorphan also causes inhibition of NMDA receptors, which is why the NMDA camel is tethered to that post. The physiologic mechanism of cough is complex, and the specific action of the opioid antitussives is poorly understood. Nonetheless, many strong or partial mu-agonists are also effective antitussive agents. All right. It's time to talk about the side effects, because the principal side effects of opioid analgesics with affinity for mu receptors are on the CNS, and that's why, besides the intended analgesia, opioid analgesics such as morphine and fentanyl can cause significant sedation and respiratory depression. She is looking a little sedated, for sure. Let the cerebral towel she has wrapped around her head remind you of the significant CNS adverse effects associated with opioid drugs. Drowsiness and clouding of mentation are common side effects of opioids, especially in the elderly. The combination of morphine, for example, with other CNS depressants, such as the sedative hypnotics, may result in very deep sleep. Opioid analgesics produce significant respiratory depression by inhibiting brainstem respiratory mechanisms. Depicted here by her deflated pulmonary life vest, respiratory depression is dose-dependent and may be initially seen as an increase in alveolar PCO2. In patients with asthma, COPD, or other pulmonary disorders, this can lead to fatal respiratory impairment. Virtually all opioid agonists cause constriction of the pupils, or meiosis. At Sketchy, constriction of the pupil is represented by the constriction of an eyeball-evoking hood, just like this one here, incorporated into the drawstring hoodie of the resort janitor. Uh-oh, that plunger. We all know what that means. It's our recurring Sketchy symbol for constipation. Little extra reminder of that common opioid-induced side effect. Remember, this effect is actually taken advantage of clinically to treat diarrhea with agents like loperamide and diphenoxylate. Constipation is a major problem, however, in the use of opioid analgesics for severe cancer pain. Besides GI smooth muscle, opioids also cause contraction of biliary smooth muscle, which can result in biliary colic. And that's why we sketched in this biliary tree. Pun very much intended. We've even got our recurring gallbladder seagull perched on top. Opioids are classically associated with sphincter of Oddi contraction, which may result in reflux of biliary and pancreatic secretions and elevated plasma amylase and lipase. All right, other than the toxic effects of opioids that are direct extensions of their pharmacologic actions, one of the most important adverse effects to keep in mind with patients with long-term opioid therapy is the development of tolerance. At Utopia Resort, tolerance is our mantra. Doesn't matter your gender or creed, whether you're a Neil deGrasse Tyson fan or an old-school Carl Sagan groupie, all are welcome. I mean, those are public restrooms, after all. Opioid tolerance is a phenomenon whereby repeated doses of opioids have a diminishing analgesic effect, and increased doses are required to achieve the same level of pain control. After only a few days of exposure, a high degree of tolerance will develop to the euphoric, sedating, and respiratory depressant effects as well. See that out-of-order sign behind the janitor, though? Looks like technically not all are welcome. At least not while that bathroom is getting fixed. With that drawn-in, eyeball-evoking hoodie and that constipation plunger, our janitor here should remind you that tolerance to constipation and meiosis does not readily occur. This comes up on every exam. Constipation is the most common persistent opioid side effect. Patients who require prolonged opioid therapy should receive a prophylactic bowel regimen, increased fluid intake, fiber, laxatives, to minimize constipation. Another thing to watch out for when your patient is on chronic opioid therapy. Turns out that long-term activation of mu-opioid receptors on nociception-transmitting neurons can actually cause increased pain sensitivity. What? This is called opioid-induced hyperalgesia, and it's represented here by this amateur acupuncturist jamming that needle straight through that placebo effect and right into one of his spinal nerves. Hey, whatever it takes to line that chi. It's not really known why this phenomenon occurs, and it could have something to do with the downregulation of opioid receptors or upregulation of glutaminergic pathways. Accompanying the development of tolerance is physical dependence, which means that your body adapts to chronic use of opioids. And if the drug is stopped abruptly, you'll start experiencing characteristic withdrawal symptoms. They're embodied here by our next guest, who looks a little unaccustomed to how cathartic these withdrawal spas can be. The signs and symptoms of withdrawal include rhinorrhea, lacrimation, yawning, hyperventilation, hyperthermia, muscle aches, vomiting, diarrhea, and anxiety. Just think of this guy here in the spa. Hyperthermic for sure, kind of moist, letting his fluids flow, definitely anxious, and letting loose one of those characteristic yawns. Also, he's definitely got some mydriasis going on there. When these symptoms occur after abruptly stopping administration of an opioid analgesic, or let's say an illegal opioid narcotic like heroin, it's called abstinence syndrome. With morphine or heroin, withdrawal symptoms usually start within 6 to 10 hours after the last dose, and peak effects are seen in 36 to 48 hours, after which symptoms gradually subside over days. Detoxification programs involve curbing these withdrawal symptoms and slowly weaning the patient off of the drug. Methadone is a potent mu receptor agonist used for this purpose. During the detoxification process for a patient with opioid use disorder, their usual drug is discontinued. However, rather than suffering a withdrawal syndrome, they're started on a monitored regimen of methadone instead. Think of methadone as this jacuzzi timer that's clicked into the done position. Done with withdrawals, that is. And that's why it's time for this guy to exit the spa. As a mu agonist, methadone has many of the same properties as the other opioid analgesics, and it will immediately attenuate those acute withdrawal symptoms. Take a look above the guest exiting the withdrawal spa, and you'll notice those long tapering flags, our recurring sketchy symbol for agents with extended serum half-life. Methadone has a long half-life. Once methadone has tapered off, its effects slowly subside. The withdrawals are much less intense, and the patient can be slowly weaned off of opioids altogether. So remember, in the treatment of opioid use disorder, it's that long half-life that we're looking for, and that's why methadone is so useful as a substitute for the shorter-acting, more rewarding opioids, such as heroin. The partial mu agonist, buprenorphine, is another long-acting agent used to treat opioid use disorder. It's represented under those long half-life flags as this buprenorphine blueprint, alerting the guests as to the location of each emergency shutoff switch that will bring this withdrawal spa to a halt. Buprenorphine is a mu agonist, so it immediately attenuates withdrawal symptoms, but because it's only a partial agonist, it's safer than methadone replacement therapy. And because it's got that long half-life, its effects slowly subside as it's tapered, and any withdrawal symptoms are much less severe. Pop quiz. You're called into the newborn nursery to check on an infant who 2 days ago was born to a mother who is Hep C positive, schizophrenic, and has no prenatal care. The baby is crying, sneezing, tachypnic, and having tremors and diarrhea. What's the most appropriate drug to administer to reverse these symptoms? Then it dawns on you. The mom has limited prenatal care and Hep C, possibly with a history of drug use. And the baby is showing all those moist symptoms of opioid withdrawal: diarrhea, sweating, sneezing, crying. Just like this baby over here in the withdrawal spa, as he gasps for breath, remember that tachypnea and irritability are common as well. This newborn is suffering from neonatal abstinence syndrome due to withdrawal from opiates that were transmitted across the placenta from the mother. So, how do you treat it? Well, these are withdrawals, so you need a mu agonist. Usually morphine or methadone is used. Quick word about partial mu agonists. Recall that over at the massage parlor, these guests are getting full body massage and acupuncture. That's because most opioid analgesics, such as morphine and fentanyl, are pure opioid agonists at mu receptors. However, over on the left side of the resort, guests have the option of just getting a partial massage, like the foot massage that this customer is getting next to the spa. This will represent partial mu agonists, such as buprenorphine, nalbuphine, and butorphanol. All these agents have that bu-fin-sounding name, so our partial massage customer holds a menu from the Blue Fin restaurant, just one of the numerous world-class dining options you'll find at Utopia Resort. Here's the thing to remember about partial agonists, however. Although these agents normally exert analgesic effects, if a patient is getting a full opioid agonist, such as morphine, throw on a less potent partial agonist, and then it's just like administering a mu antagonist to your patient. What this means is that you'll actually precipitate withdrawal symptoms. It's kind of like this bluefin waiter here, stumbling over the partial foot massage and toppling headfirst into that withdrawal spa. And since we're on the topic of mu receptor agonists, let's talk about the pure opioid antagonist agents naloxone and naltrexone. Think of naloxone as the no-relax zone. Recall that the overly sedated, respiratory depressed lady reclining in that lounge chair represents opioid overdose. When given IV, a mu antagonist like naloxone completely and dramatically reverses the opioid effects within 1 to 3 minutes, normalizing respiration, level of consciousness, pupil size, bowel activity, and awareness of pain. In fact, in dependent patients on chronic opioid regimen, you'll instantaneously precipitate an abstinence syndrome. So, throw off that CNS depressing towel and put on that respiratory vest, because it's time to hit the withdrawal pool. Another option in the treatment of opioid use disorder is combination therapy with buprenorphine and naloxone, more commonly known by the brand name Suboxone. This is symbolized by the kid in the boxy submarine float running between the buprenorphine blueprint sign and the naloxone no relax zone. Naltrexone is another mu antagonist, hence the word no emphasized. Again, this time, however, you've entered the no tricks zone. When naltrexone is administered to a patient every few days, it blocks virtually all the effects of heroin. Long-term, this can help patients maintain abstinence. There's also evidence that naltrexone reduces alcohol cravings in patients with alcohol use disorder, reduces nicotine cravings, and can help with weight loss. Well, that about does it for our tour of Utopia Resort, and This sketch all about opiates.